Over there.
Okay, we're gonna run through me demonstrating RSI. So we'll see how it goes. Who's gonna be partner? No. So in this, you're going to walk into a station and you're going to find out that we've already met the indications. So one of the three either failed airway patency or protection, failure of oxygenation or ventilation, and not candidate of non-invasive positive pressure ventilation, or predicted clinical course. So we're going to say we've met one of those three or more, and we've confirmed that intubation is not delaying a more important decision. Partner's probably bagging this already for us, so we're going to put the BVM on. We'll turn the monitor on. It probably is on at this point if we're in truth, and we'll make sure that we have a full set of vital signs. You're nailing it, thank you. I'm just going to hit NIVP, and we'll make sure that we have end-tidal CO2 in our stack, and that we're ventilating well. And SVO2 is currently 88%, 92. We'll see where that goes. So, am I getting good chest rise and fall at this moment?
You are.
Okay, and I'll just auscultate bilaterally. Okay, so we see a waveform now of 45, and we've sat in 94. So oxygen's on at 15 liters through the bag valve mask. If I had a second regulator, then we put 15 liters through the nasal cannula as well. And we might as well sit up just 30 degrees, try to improve oxygenation. So currently not having any problems with difficult ventilation. Oxygenation is going well. We'll be aiming for SATs of 100%, so they should come up. Am I hearing any adventitious sounds in the lungs?
We're not.
You're not. So we'll SATs will likely come up with that supplemental oxygen with an appropriate respiratory rate and minute volume. So now we have, we look at our blood pressure. We've got a blood pressure back of 92 on 59. So that's a little bit low. We're going to start an IV, and we'll go ahead and I'll share the video. So go ahead, start an IV, and we're going to start with a 500 ml bolus. My phone is recording. Set timer for 5 minutes. I'm normally using my multi-timer on my phone, but it's there, so I can't take it. So we'll say we'll start a saline bolus, and we'll say we've done a differential as to the reason of shock. We don't have any overwhelming reason for a low blood pressure and a high heart rate. We would have to have a reason. Do you want to give me a reason, or do you want me to just say as far as why do I have a heart rate of 136 or blood pressure 92 on 59, or we'll just say it is okay right now, it is low?
Well, we can say that. We could also say we have an anaphylactic, we're in a rural station, it took about 30 minutes to get there, so they're quite late stage.
So, okay, so we'll put the anaphylaxis yet, because that might change a few things. So it'll rely. So let's just say old person with a little bit of a soft blood pressure for the time being. Is that all right?
You got it.
We will get there, I promise. Because if not, I'd have to do some other things like epi, lots of epi, and start an epi infusion and other things. So we're just going to bolus a little bit of fluid, and we'll prep our push dose presser. So I'll grab my preload and drop my preload of my saline. And we're going to just push out a mil, so we have 9 mils of saline. I'll come around so the camera can see. But we're just taking 1 milligram in 10 mils, and we're just going to take that and drop 1 mil into this 9 mils. So we'll have 100 micrograms in 10 mils. So 100 micrograms in 10 mils. And we'll go ahead and tape that to the side. Okay, so we're ready for that. Pressure fluid's going in. And we'll come back and check on that pressure here in just a second. So we don't have any evidence. We do have a high shock index, so we've prepped some push dose, some epi. Do we have any evidence? No reason to think of acidotic state. Wasn't breathing fast intrinsically themselves. Low end-tidal CO2, septic DKA, renal failure. Don't see metabolic acidosis. So we're going to look externally and just evaluate. Do I see a narrow face or a large overbite or underbite? So can I just pop that off for just 1 second? And I'm just going to measure here and see how many fingers of comparative their fingers. So I get about 2 fingers here and 3 fingers there. I'm going to just have a peek at Mallampati while I'm here, and I can see it's not a true Mallampati, but I can see structures. So 2, 3, 2, and 1. You can throw that OPA back in and ventilate, or if you're getting good ventilation as is, just keep ventilating your fine. So we've done look externally, evaluate Malampati. We have no obesity or obstruction, so no third trimester pregnancy, any stridor, morbid obesity present, and neck mobility. Am I able to put him up into sniffing position?
You are.
Great. We have no beards. We're an older patient. We're currently ventilating. We don't have any obstruction that we've talked about. And we have teeth in place, and we heard sounds, we heard no sounds in the mouth or in the lungs. Moods, we have mouth opening that was 2 fingers. I feel like I can get my extraglottic in there. No distortions in the throat, and we don't have any sounds or stiff lungs, and we're getting easy compliance. DART, no distortions over the anatomy. I'm able to put my finger on the spot. Any radiation history to the neck?
Not that we know of.
And no trauma or tumors. So this seems like an intubation that will be successful, and my backup plans are ready. So I'm going to go ahead and just go through my contraindications for airway medications, and then we will motor on. And I'm missing a page. That was kind of you. I'll pull up my application and I'll go say, so succinylcholine, no hypersensitivity, so family no history of. Any suspected hyperkalemia, so no history of renal failure. We're not suspecting sepsis, DKA, no ethanol overdoses. There's many other, so glomerulonephritis, lupus, we don't have any of those conditions. So we don't have a reason to believe this patient is hyperkalemic, no recent burns or traumas that have been greater than 24 hours. No history of family or personal or family history of malignant hypothermia, and no degenerative muscle diseases, ALS, muscular dystrophy, Parkinson's, nothing like that. Okay, so ketamine, we don't have hypertension. Fluid has gone through. We got 9 seconds left on our fluid. And we'll just turn, if that's 109, we'll give another 250, and I'll set another timer, set timer for 2.5 minutes. So, no contraindications for ketamine. So we're gonna go ahead and set up stop IC bars. So I have my stylet and my suction. So stylet and suction. I'm actually gonna use my bougie first. So I'll just have that easily available. So T is tubes, so we'll say this is female, so we'll go with a 7 and a 7.5. So I'll pull those out and have those available. Oxygen, P is for pharmacology, so we're going to 1.5 milligrams per kilogram of each. I want somebody's calculator. Thank you. So what's my patient weigh?
So we've got a 135-pound patient.
135, so 135 divided by 2.2. And we are at 61 kilograms. I'm writing in crayon now, 61. So we get 61 kilograms. My succinylcholine is supplied in 20 milligrams per mil, so I'm going to divide by 20. So succinylcholine equals, I'm sorry, oh yes, no, that's right. So we only want 60, so we want 3.06, so I'll give 3 mils of succinylcholine, and our weight is 61, and ketamine is supplied in 50 milligrams, so I'll divide that by 50. 61 divided by 50 equals 1.2. Okay, so succinylcholine at 3 mils for small dosages today. So 3 milligrams, or 3 mils of succinylcholine. Don't trip over the line. And ketamine, I want a smaller, that'll work. I got 3, that'll be fine, 3 will be fine. So 1.2 mils of ketamine. Okay, so ketamine's here. I'm just going to recycle that blood pressure. We get another 250 in. What do we got? So I guess we'll hit the blood pressure again. So now we're confirmation. We have CO2. We have. I got my 2 syringe here as well, if I should need that. And bars. So we've got a bougie. We have alternate, so I'm just going to call it alternate blades and tubes. So I'm going to take a Miller and I'll size 4 and a 1, or a large Miller blade. And we have our alternates, so we're going to go over and grab our extraglottic device and our surgical. So I'm going to use an eye gel, and we'll use the appropriate size for that patient. That's big for this patient, but we're just have the one here for the time being, so remind me and I'll run down and grab you. We have the surgical. I see a scalpel, and I don't see a size 6 tube, which would need. We'll say there's a size 6 tube in that kit, but it's currently not complete. Stop IC bars. Patient's positioned well. I'm at the head of the stretcher at an appropriate height. Be able to be below my belt level. So what my plan is to do is I'm going to go in with a video laryngoscope. If I have any problems, I'm going to do a head lift. I might ask for some burp. So I might need you to do that for me. You're familiar with that?
Yeah.
Might ask for some brutane. That's where you put your hand with mine on the laryngoscope and pull. I'll probably pull and then ask you to hold it there. And then if I'm not successful with that, I'm going to do the same maneuvers with the Macintosh blade and with the mill. If that doesn't work, we're going to declare that intubation has failed. I'd like you to watch the whole time to see if SATs drop below 95%. I'd like to know. And if they go between below 92, you got to tell me to get out and start ventilating again. So if I'm unsuccessful in intubation, I'm going to try the eye gel. If that's unsuccessful, we'll try the bag valve mask. And if that's unsuccessful, we'll go to the surgical airway, which I don't anticipate. Do you have any questions?
Ready to go.
Okay, good to go. I'm just going to recheck blood pressure and SATs. So everything's looking good there. We're going to pick up our ketamine and we are going to, everyone ready? We got this. Okay, so we're going to give her ketamine. That will be over 1 to 2 minutes. So I'll administer my ketamine. We'll just say, for the sake of time, that we'll say that ketamine is in. We'll open that line and flush after that ketamine. So ketamine is in. As soon as that ketamine's in and flushed, we're going to go ahead and push our succinylcholine. We're going to go to the top of the stretcher. And we're going to just assume I'm just going to take that over. Perfect. Thank you so much. And you can just stay right here, and I'll just need your help if you want to. I'll just fire that on. And we're just going to be waiting here for a minute to see, do we have good, so when do I see fasciculations? We'll say a minute goes by and I see fasciculations. So I'll just lower the head down just a little bit and set that down out of the way. Beautiful. Just make sure if we didn't switch the oxygen over to the nasal canyon. Just going to insert my laryngoscope and walk my way down the tongue. Okay, I've got a grade 1 view, so I'm just going to take my bougie because I'm at kind of a steep angle here. Insert my bougie. Ahead. And do you mind handing me that too? Thank you so much. Do you mind threading it over the end? I'm just kind of limited to one hand for the time being. Thank you. Okay, we're black line at the tube, so we're going to just pinch off, turn our laryngoscope off, bougie out, plate the cuff. Maybe? Do you want to hold that right there? Yeah, sure. Perfect. It's like me and my shaky hands. So cuffs inflated. First breath, looking at end tidal CO2. So I have end tidal CO2 return. Can you just continue to breathe 1 breath every 6 seconds? I'm just going to auscultate apices, and I'll just squeeze here while I'm listening. We can hyperventilate for a second. Do I have air entry bilaterally?
You do.
Okay, I'm just going to cycle another blood pressure and look at my SATs. SATs are at 96, and we'll cycle a new blood pressure. And I'll just go back to my checklist. So we've inflated the cuff, we've done CO2, we're at the right depth. We're ventilating appropriate. We're back on oxygen, so if we connected the nasal, we'll put the oxygen back on the bag valve mask. We're at 30 degrees, so let's go ahead and put them up to 30 degrees. And do we have any hypotension? I'm going to secure that in a second. Just more concerned about the hypotension. And we're going to prepare for sedation. So 125, so we have no hypotension. So I'm going to go ahead and secure our tube. And after that, we'll prepare sedation and prepare to address dope and put an OG tube down. And that's it. How much time?
15 minutes, 35 seconds on the camera.
Perfect.
Yep.
Let's stop there. What
Sit
did
down.
I miss?